Hello, everyone. This is Jeanette Gass. I'd like to welcome you to the 2021 Global Year webinar, Promoting a Foundation of Resilience Among Adults with Chronic Low Back Pain, presented by IASP. Before we get started today, I just have a few items to go over. You can type your questions into the Q&A section of the Zoom meeting control panel window. If you have general questions, you can use the chat box and we can answer them there. The presenters will be able to answer the questions in the Q&A. The recording will be available after the live webcast, and everybody that's registered will receive an email when the recording is available. You can tweet using hashtag Global Year 2021, and you can follow IASP Pain on Twitter, and you can visit our website for more resources. I'd also like to remind you that the IASP 2022 World Congress on Pain registration will open in early January. We invite you to join us all in person in Toronto, Canada in September. And now I'd like to introduce our moderator, Dr. Kimberly Seville. She is an associate professor in the Departments of Physical Medicine and Rehabilitation and Anesthesiology in the Division of Pain Medicine in the College of Medicine at the University of Florida, and is the director of the Pain Trail Translational Research and Assessment and Intervention Lab. She has a background in exercise science, a master's degree in counselor education, a doctoral degree in psychology and clinical psychology with concentrations in neuropsychology and health psychology, and postdoctoral training in clinical and translational pain research. Her research efforts are specific to investigating the biological interface of chronic pain, resilience, and factors contributing to health disparities based on an established physiological model. Her lab has developed a pain phenotyping measure, chronic pain stage, with findings spanning biological, cognitive, and physical functioning. Additionally, research is underway on a pain resilience index that is biologically predictive and clinically applicable. She is currently funded by the National Institute on Aging and National Institutes of Mental Health. I'd like to now send it over to Dr. Seville to introduce our presenters.
Oh, Kimberly, you're muted. Okay, there we go. So thank you for the introduction and welcome everyone. It's truly a pleasure to be able to serve as a moderator for this session. And I think it's going to be a really interesting topic to address, and it's hugely important as we head forward in treating chronic low back pain. So our seminar title is Promoting a Foundation of Resilience Among Adults with Chronic Low Back Pain. So resilience is a concept we've actually thought about for thousands of years, but it's becoming more and more of an area of interest in the more recent years. And there's numerous definitions for resilience. But when you look across all the definitions, there's a general consensus that resilience is the ability to successfully adapt to stressful events and adverse conditions. But I think as we think about this term, resilience, that there's a key phrase that often coincides with it, and that is stress. And when you look at patterns of nature, suggests that resilience is developed in response to challenge and change. Essentially, stress serves as a stimulus that can promote strengthening, striving, adapting, advancing, and thriving. So chronic pain, specifically chronic low back pain, is a worldwide issue. But for individuals living with chronic low back pain, it is a significant stressor. Research specific to psychosocial resilience factors has really provided some guidance on what are clinical targets and the treatment of chronic pain. But if you look across this list, I think what you're going to recognize is the same psychosocial resilience factors that have been shown to be protective in chronic pain are actually protective across essentially all health conditions and truly related to human performance and functioning. So what's important, though, is to realize that resilience is not limited to psychosocial factors, and that we know health behaviors are also a key component of resilience, and that protective health behaviors are not only associated with lower levels of clinical pain, but are associated with reduced levels of morbidity as well as mortality. And there was a super nice publication on the relevance of health behaviors and their protective role by McFarlane and colleagues. And so as we think about resilience, one of the, I think, exciting aspects is that there are multiple domains for resilience, which identify numerous potential targets for interventions. And so a way to conceptualize this are psychological factors, there are behavioral factors, there's social factors, and there's biological factors. Now, genetics don't lend themselves to being particularly modifiable, but it's important to keep in mind that interventions across any of the other domains actually have a biological interface. So our three presenters are going to talk about their work identifying and investigating modifiable targets to promote resilience in individuals living with chronic low back pain. And so we're going to start this seminar with Dr. Burl Gooden, who's an associate professor from the University of Alabama at Birmingham. And Dr. Gooden's going to highlight emerging research on individual factors of resilience that diminish the severity of chronic low back pain and disability and discuss future directions for pain management. Following Dr. Gooden is Dr. Melissa Day. Dr. Day is an associate professor at the University of Queensland, and she's also an affiliate faculty at the University of Washington. Dr. Day will discuss the need to move towards personalizing evidence-based treatment approaches, extending beyond interventions that work for a specific pain condition and really focusing to individualize treatment based off deficits and inherent strengths. And then following Dr. Day will be Dr. Emily Bartley. Dr. Bartley is an assistant professor from the University of Florida, and she will highlight treatment approaches that promote resilience and improve pain coping, and specifically talk about some findings from a group-based clinical trial that's been aimed at enhancing psychological resilience among older adults with chronic low back pain. So please, as you have any questions, feel free to either load those in the chat or the question and answer section. How we're planning to organize this is for the three presenters to present, and then we have some time set aside to address questions and discussion. So with that, I'm going to turn the screen over to Dr. Gooden.
All right, thank you kindly. Let me load this up here. All right, and start from the beginning here. And let me minimize this screen so I can see what I'm doing. All right, folks, so promoting a foundation of resilience among adults with chronic low back pain. Let's get on to it. Thank you for that great introduction there, Dr. Sibyl. So I always like to start off with my acknowledgements. This is my great team of collaborators and investigators in my biobehavioral pain research laboratory. They are way more important to getting this work done than I am at this point, and recognize that generally if I say I did something, what I mean is we did something. And if I say we did something, what I probably mean is they did something. So these are the important folks to keep the wheels rolling on the lab. If by chance I make a mistake here this afternoon or happen to fall asleep, it's because of this young lady here. This is my 7-month-old daughter. We had a rough night last night and the sleep deprivation is real. Okay, getting into it. So really my interest in pain resilience and positive psychological factors started back when I was in graduate school. At the time, I was working with a lot of folks who were talking about risk factors and why certain individuals really do more poorly with their outcomes, their responses to treatment. And while that's certainly intriguing and interesting, I was thinking, like, conversely, if we flip that, why do some people do better? Why are some individuals seemingly not as affected or not as bothered by their chronic pain? So I started looking at temperament and disposition, and that brought me to optimism. In that top left corner there is actually some work from my PhD dissertation relating optimism to experimental pain modulation. And then from there, wrote a little bit more on just overall experiences of optimism and pain, which brought us to some work. You'll see my colleague, Dr. Bartley, who has some shared authorship there with me and some work that we've done together looking at optimism and its sort of crosstalk with psychological resilience and being beneficially associated with clinical and experimental knee pain in adults with knee osteoarthritis, and to what extent things like optimism are associated with less risk factors or the engagement of less problematic sort of psychological processes like pain catastrophizing. So this is kind of where it got going and what brought me to where I'm at now, which is still really looking at sort of multi-domains of resilience and how that confers benefit to pain. So we already had a basic definition of resilience from Dr. Sibyl, and I appreciate that. But broadly, we're talking about the ability to cope with a crisis or adversity while maintaining your positive emotional and psychological functioning. And that's general resilience across the board. And there's some good ways of measuring that exist out there. For example, things like the Connor-David Resilience Scale, the Resilience Scale for adults, and the Brief Resilience Scale, all measures that we previously used. Again, a little bit more general in terms of basic psychological resilience. However, in more recent years, there has been some thought that it may be prudent to really kind of narrow things down to pain-specific resilience. And this is a nod to some of the great work that was done by Brett and Cowie and Max Slepian out of Christopher France's lab at Ohio University, I think back when they were graduate students, where they were really kind of conceptualizing pain-specific resilience, the ability to maintain relatively stable, healthy levels of psychological and physical functioning in the face of ongoing and persistent pain. And we've included some of this in our work and actually have shown that while the more general measures of resilience are indeed related to pain outcomes, the pain-specific resilience measure is even more strongly related. And I think that's the essence of what these previous investigators thought might be the case. So to think a little bit more on Ann Cowie, Slepian, and Chris France's pain resilience measure, factor analysis really showed that there were two primary domains in this measure. There's a cognitive and affective positivity, which reflects, as you can see, item level factors or item level contributions to the factor there. Things like I keep a positive attitude, doesn't affect my happiness. I keep a hopeful attitude. I don't let it get me down. Alternatively, you have behavioral perseverance, or things like I get back out there, I work to accomplish my goals, push through it, and stay active. So the overall pain resilience scale and then the two subscales will be reflected in some of the slides I'm about to show you. So I just wanted to sort of give you an indication of what is thought to sort of be subsumed under pain resilience, this cognitive affective piece, this behavioral perseverance piece. So we wanted to include this measure in our ERASE study, which is examining racial and socioeconomic disparities in chronic low back pain study. And this is a large study that we got going back in 2017 that was funded through our National Institutes of Health here in the United States. 5-year study. That 5-year period just is wrapping up now. And we've got one more year next year as a no-cost extension. So we got a good amount of data that's still being collected and that we've just collected on this. But all this data was collected consistent with the sort of recommendations by an NIH task force on research standards for chronic low back pain. So we've got a good amount of comprehensive data on this topic. All right. So just to give you a brief overview of who our participants are, we have 200, at least at this point, 200 individuals with chronic low back pain. This is primarily non-specific chronic low back pain, individuals who were recruited through our pain clinic who had back pain that was really related to things like fracture, infection, maybe neoplasm, cancer were excluded. And these were individuals who really didn't have a highly discernible reason. I always use reason in air quotes, being that pain's a subjective experience, but who didn't have a highly discernible reason for their chronic low back pain. All right. So what you can see is this is basically sort of a midlife sample, about 45 years of age on average, roughly even split between self-identified men and women. In terms of racial breakdown, we're a little bit more primarily African-American and Black individuals, where the other 40% of individuals identified as Caucasian white individuals. But there's a decent number of individuals, almost 38%, who weren't working, and then a smaller fraction of those individuals who were on disability benefits, didn't have health insurance. What you can actually see is that the vast majority of our sample, 33, almost 34%, reported an annual household income of $0 to $20,000 US. Excuse me. And that'll come into play again a little bit down the road as it relates to poverty versus affluence, at least in America. And I'm trying not to be too US or American centric here, thinking that this is an international audience. Again, recognize that these data were collected here in the United States. The vast majority of our individuals had chronic low back pain for at least a year or longer, with 30% of them having chronic low back pain for over 10 years. And the vast majority, almost 80%, reporting that pain severity to be moderate or severe. 14% of the sample reporting current use of an opioid prescription for pain management. So this just gives you a little bit of an idea who our folks are. All right. Pain response measures that we assessed in this study. So we wanted to get sort of a multimodality of pain measures. So we have the brief pain inventory, asking things about worst pain, least pain, average pain, pain right now. More of a functional assessment with movement evoked pain. We have the time up and go, and that's up in the top. So that's from a seated position, getting up, walking 3 meters, turning around, and sitting back down. So that's timed. And then also individuals report from 0 to 100, how much pain they felt in their back while doing that. And then last but not least, we had a quantitative sensory testing pain response measurement, temporal summation of mechanical punctate pain here, where this punctate probe was placed into the sacrum at the erector spinae muscle one time. Person reported 0 to 100, how much pain they felt. And then after 10 consecutive probes, how much pain they felt after that, and the difference between pain intensity at first prick versus pain intensity after the 10 pricks was thought to represent their temporal summation of mechanical pain. The mechanical pain stimulus was 512 millinewtons. Okay, so in a series of slides, what we have here is BPI, brief pain inventory, severity of chronic low back pain, broken down on the left according to their pain resilience reports on the full scale, pain resilience of the 2 subscales. In the middle is the behavioral perseverance subscale, and on the far right is the cognitive affective positivity subscale. Okay, so what you see here is that in the middle, the only real significant correlation between pain sensitivity and pain resilience was particularly for the behavioral perseverance subscale. So what this suggests is that individuals who report more behavioral perseverance as an aspect of pain resilience reported less severe pain. Okay. Same sort of setup, but this time for the timed up and go test. Now, the pain resilience itself wasn't actually related to movement evoked pain. the tug wasn't too effective in eliciting movement-evoked pain, but in terms of the efficiency with which they actually completed the task, what you'll see here is that across the board, those individuals who reported more pain resilience generally completed the timed up and go in less time, suggestive of greater functioning. But as you can see in the middle with the circle around it, the strongest correlation there, again, was for behavioral perseverance. And then last but not least, with the temporal summation, you see that on the far left, the overall full scale for pain resilience was associated with less temporal summation, meaning greater pain resilience, less temporal summation. But again, the middle scatter plot there being circled because that seems to be what was driving the correlation on the left, particularly greater behavioral perseverance, lower temporal summation of pain. Okay. All right. So we also had all these individuals with chronic low back pain complete this Oswestry Disability Index, which is a pretty well-known and gold standard way of sort of identifying level of disability, right? According to minimal, moderate, severe. There's cripple, which I don't really like that term too much. I think it's kind of representative of the old times when this was created. So that's more of a complete disability. And then this 81 to 100, you see here, like patients who are bedbound or perhaps exaggerating their symptoms. I don't really like to accuse too many people of exaggerating their pain symptoms, but the fact is that we had 5 participants who were in this category. They weren't necessarily bedbound because they came into our laboratory to complete the study. Again, I don't want to say they were exaggerating their symptoms. It was just much easier to exclude those 5 individuals. So what you'll see in the next slide is we have minimal, moderate, severe, and complete disability breakdowns. And what we did is we sort of stratified our pain resilience across those designations of disability. On the far left, you can see that as disability becomes more severe and complete, those individuals are reporting less pain resilience. Interestingly, it appears to be that they're reporting significantly less behavioral perseverance. This is, again, being able to engage and maintain their day-to-day activities. When it comes to maintaining sort of positive affect and a more positive outlook on life, although there's a trend to suggest that those who are more severe or completely disabled have less, it's not significantly different. So again, it's this behavioral perseverance piece that really seems to differentiate sort of mild, moderate, and severe chronic low back pain. So speaking about sort of the promotion of resilience in the face of pain, this is a very nice review article from a couple years back by Goubert and Trompeter that talked about different sort of theories or models that might engage the promotion of resilience. Speaking about psychological flexibility model, broaden and build theory, and self-determination. Based upon my read, the broaden and build and self-determination, a little bit more about promoting the positive sort of cognitive and affective pieces here. As you can see from the patients that we enrolled, they're not necessarily struggling in that regard. It's the behavioral perseverance. And what I can tell you from my time, treating patients, I don't necessarily do that much anymore. It's more research, but back in the day, anecdotally, what I often heard was some psychological inflexibility, such that if I can't do X, and you can fill in the behavior for X, if I can't do it the way I used to, what's the point in doing it anymore? And then without engaging in those activities, you get the deconditioning a la fear avoidance model from Valayan and such, where you get the chronification of the low back pain. But this is why I have psychological flexibility highlighted, because I really think that, through sort of promotion of psychological flexibility, think acceptance and commitment therapy, that if you can sort of promote some cognitive diffusion, get people to be a little less rigid in how they think and do things, that you might actually be able to still engage them in some behaviorally perseverant types of things, despite the chronicity of their low back pain. Again, just my thought there. Okay, so there has been, a decent amount written in the last decade about what are the determinants or indicators of resilience: psychological, biological, socio-environmental. And as you can see in the top left slide here from Lou and colleagues, is there's been, in my opinion, more discussed about promotion of biological and psychological resilience through various treatments like cognitive behavioral therapy or acceptance and commitment theory, psychologically speaking. Biologically, perhaps things that might modify neural circuitry, like brain stimulation such, and things like that. But socio-environmentally, I feel like there's been less addressed in terms of how it might even relate to resilience in general, let alone pain resilience, or how you might intervene. And with the ERASE study that I mentioned to y'all, this is where I really want to show you what I believe to be some interesting data that's popping up out of our ERASE low back pain study. So given the sizable or sort of large focus on sociodemographics, we had a greater assessment of sociodemographics than just tell us about how much money you make and what your education was. So here are some examples of questions that we asked. Now, granted, what is your current annual household income? Always important to ask. And we would also then reconcile that in light of the number of people living in the household, because at least in America with various guidelines, that will allow you to determine sort of who's above or below the poverty level. Recognizing, and again, this is my opinion, but I feel pretty strong about it, that you might actually be above the poverty level, but that doesn't mean that you're affluent and that you're not still struggling financially. So that's why we also got into questions about how financially secure do you feel for the future, such that financial security refers to peace of mind, having enough income to meet your needs. How satisfied are you with your current standard of living, right? Which standard of living refers to level of wealth, material goods, resources, and comfort. And what you can see there in the little martini looking glass, I think that's meant to be a funnel, are the various correlations with pain resilience, the total scale. So greater income, greater financial security, greater standard of living, greater pain resilience. So does money buy resilience to chronic low back pain? Likely not, but as this purple flower quote here says, money may not buy you happiness, but it's going to make you awfully comfortable while you're being miserable, right? And it makes a big impact as a socio-environmental contributor to your resilience, right? There's been things written about the potential role of anti-poverty programs in promoting health promotion. To the best of my knowledge, there really hasn't been any durable, sustainable anti-poverty programs, at least in the United States, but perhaps across the various continents that have really been able to promote health and resilience therein. At least in the United States, you talk about anti-poverty programs, you're talking about where does that money come from? Perhaps that's subsidized with tax dollars. Anytime you start talking about that, it gets real political real fast, and then it can get real nasty and off the rails. But anyways, just from a purely scientific perspective, there has been some small studies and some things that suggest that just giving people cash, not necessarily access to resources or vocational training, but just giving them cash and helping to just pull them out of poverty a bit has wide-ranging effects on their health. Okay, so the other thing to consider too is that place matters. Now, what you're seeing here, this is Jefferson County, which is a county in Alabama within which Birmingham, where I reside, is. On the left, or what you can see is a bunch of blue and red dots. And essentially what that is that each red dot represents 50 white, meaning white Caucasian households, and each blue dot represents 50 Black households. And then there are some green dots and yellow dots peppered in there representing Hispanic and Asian American individuals. But in my county, it's primarily Black and white individuals. And what you can see here is some substantial segregation by race. What makes this particularly alarming is that when you look to the right, this is how the county breaks down as a function of poverty. And if we were to, superimpose these two figures on top of each other, the most impoverished neighborhoods tend to be where the Black individuals live the most, where the most affluent neighborhoods tend to be where the white individuals live the most, right? So again, place matters. This brings us to some interesting work that's been kind of put out there recently by Dr. Amy Kind and colleagues at the University of Wisconsin at Madison, where they have spent 5 years kind of putting together a bunch of data using geocoding and census information to create these area deprivation indexes. The area deprivation index is essentially a sort of national decile comprised of 17, trying to make sure I get this right, 17 different socioeconomic variables in the domains of education, income, employment, and housing quality. Now, again, recognizing that this might not generalize outside of the United States, you get my point here, though, is that you can see where there's a lot of red and orange, which are places where the neighborhoods are severely deprived. And then there's some light blue and dark blue where those neighborhoods are highly affluent, right? So everybody who participated in our race study can, based upon their address, be given an area deprivation score ranging from 0 to 100, where higher scores would be more red, more deprivation, okay? And this is some interesting work from some trainees in the lab. Pam Jackson on the left, the PhD student, Deanna Rumble on the right, a former postdoc who's now moved on to a faculty position, really showing that this ADI, this area deprivation index, corresponds effectively with other individual level socioeconomic status variables in relation to pain severity in people with chronic low back pain. And then also too, that people with chronic low back pain who live in the most deprived neighborhoods tend to have the poorest sleep. So this work with the ADI has really been foundational to our sort of place matters argument pertaining to chronic low back pain and resilience. The resilience piece is what you see right here. So again, on the left, this is our stratification of people with chronic low back pain according to the Oswestry Disability Index and their pain resilience. We've already seen this. But what I want to show you on the right is that those individuals with the most severe and complete disability have the least amount of resilience, but they also have the highest amount of neighborhood deprivation in which they're living. Okay, so bar graphs are great for showing you data, but essentially what that means is that on the left is where you're perhaps more likely to see our most severe and disabled individuals with chronic low back pain, where on the right is where the chronic low back pain is less severe, less impactful, and those individuals tend to be more resilient, right? So this is Birmingham, Alabama, same city, two different worlds. But I can promise you that this is not just Birmingham. I've seen this across the United States, ranging from the coast, Baltimore, to San Diego and LA. But I've also seen this sort of discrepancy when I've traveled to Tokyo, when I've traveled to Cape Town, South Africa, Prague. So these discrepancies exist where it's the same city, two different worlds, okay? So what can be done about this? And this is where I want to sort of round things out by showing you some very interesting work that's not specific to chronic low back pain, right? But I think you can sort of follow me here as I sort of draw sort of a comparison of where we might be able to go with our future research and thinking about promoting resilience. So this was a study that was done by Dr. Gina South. This is like my academic crush right now. This is some of the coolest stuff I've seen in a long time. But Dr. South is a physician scientist from the University of Pennsylvania. And she and her colleagues up there conducted a study looking at the effect of greening vacant land on mental health of community dwelling adults. So what they did is they found 110 vacant lot clusters, which ultimately equated to 541 vacant lots, right? They were randomly assigned to three groups: a greening intervention, a trash cleanup intervention, or no intervention at all. And then they got participants who lived in proximity to all these vacant lots to actually be part of the study. And then it was just a pre-post of assessing mental health outcomes before and after they did the intervention. So they had 442 participants sampled, 342 included in the analysis that they were able to get follow-up data for. And they were particularly asking about feelings of depression, self-reported mental health. On the right, you can see the schematic of across the city of Philadelphia, where the greening intervention took place, the trash cleanup intervention took place, and the no intervention took place. And they tried to do this in a way that didn't systematically or in a biased way put more of the greening intervention in one particular neighborhood over the other, right? And to give you a little bit of an idea of what this looks like, on the far left is what you can see about some vacant and dilapidated lots, right? Lots of trash, doesn't look good. You look at this and it doesn't necessarily make you feel cheerful or otherwise thinking like, man, today could be a good day. The middle slide shows the efforts to sort of revitalize, and particularly during the greening of these dilapidated lots. And then on the far right is the after, where you can see that, you know, things were cleared out, cleaned up, some low-level fencing put in there, and otherwise it just looks pretty nice. And then ultimately, here's I think one of my last slides, but the greening intervention compared to doing nothing at all, those individuals who were in proximity to the greening of those vacant lots reported significant decreases in feeling depressed, or the proportion of individuals who reported feeling significantly less depressed was greater compared to the no intervention. Same sort of thing, and that effect was even stronger for individuals in neighborhoods below the poverty line, which is important to know, right? There was a trend for a reduction in self-reported poor mental health. The cleanup intervention, which was just removal of trash compared to no intervention, no significant changes in mental health. So fixing up vacant and dilapidated physical environments could be an effective intervention for improving mental health, particularly in resource-limited urban settings. My question, just in general, this is rhetorical, but something interesting to think about is, could an intervention like this perhaps benefit chronic low back pain by promoting resilience? I mean, we know that interventions that tend to improve mental health might be able to do so by promoting resilience. So with that, I'd just like to acknowledge my funding source, the pain treatment clinic that I worked out of, where I got all the important participants in this study. And I'd like to acknowledge my funder and say thank you. And I will stop sharing at that. And I know I speak fast. I'm sorry. I'm just trying to make sure that I don't hog Emily and Melissa's time.
Thank you very much, Dr. Gooden. And does not look like there were any complaints about the speed of your presentation. So you're good there. And super interesting. Looking forward to the discussion that's going to follow. Let's turn it over now to Dr. Day.
Good morning, everyone, from Brisbane. I loved seeing all of your greetings coming in from all over the world, and it's an absolute pleasure to be here, and fascinating talk, Dr. Gooden. I love that last study about the greening up neighborhoods. Super cool. I hadn't read that, so yeah, looking forward to discussion about that too. So I'm going to be talking with you about differences in treatment responses among individuals with chronic low back pain, with an idea here really to get a sense of how do we build resilience for different people, and how do we match an appropriate treatment to each individual person. And so just as a brief, first disclosures, my research was supported by the NHMRC here in Australia and also the University of Queensland that I'll be sharing with you. So as an overview, I'll touch on evidence-based practice for chronic low back pain and chronic pain in general, and then talk about heterogeneity of treatment response with a focus on psychological interventions. And then I'll present a moderation theory, which is a preliminary model that my colleagues and I have developed that really looks at how do we match people to various evidence-based treatments on the basis of not only deficits, but also strengths that we can enhance and build upon. I'll then present some preliminary data from a pilot randomized controlled trial that tests this particular theory, and then finish with summary and conclusions. Just as a little bit of context, I'm sure in this audience people are quite aware, but chronic low back pain is a massive problem globally, with point prevalence estimates of 540 million people reporting activity limiting low back pain at any one time. And low back pain is the leading cause of disability worldwide. Importantly, though, for most, the clinical course is benign. So for most people, so they estimate 95% will actually recover. However, there's also very high rates of recurrences for people that experience an episode of low back pain. And for a small proportion of individuals that experience low back pain, they will go on to experience chronic pain that persists. And of course, with chronic pain as well, there's fluctuations in that. It's not like it's just always the same, but it is pain that persists and is experienced on most days of the month for at least 3 months. Importantly, non-pharmacological approaches are the recommended first-line treatment approach for chronic low back pain. And so the traditional chronic low back pain treatment pathway then, in terms of evidence-based practice, in a brief, quick nutshell, first off, the patient receives a chronic low back pain diagnosis. It might be a non-specific low back pain, or there might be an identified cause, but nevertheless, they have a low back pain diagnosis. Then an evidence-based practitioner will look at what treatments have been shown to be efficacious for that particular condition. And then the other piece of evidence-based practice is then, does the therapist have the expertise to deliver a treatment that's been shown to be efficacious? And another piece of this as well that's often left out of the discussion around evidence-based practice, it's not just about clinical efficacy trials, but it's also what are the patient's preferences. So presenting them ideally as a therapist with a menu of evidence-based options for their particular condition and eliciting their buy-in into what treatment they would prefer. The idea here, though, is that we really need to move beyond this to have a more precise approach to applying evidence-based practice. Because even though something like cognitive behavioral therapy, for example, has been shown to be efficacious on average, within those trials and within those results, there's a great deal of variability in response. And so for some individuals, cognitive behavioral therapy or other approaches like mindfulness work very, very well. But for others, they'll only get moderate response. And for other people as well in these group averages, they actually get worse. And so really what we need to do is, with this menu of options that we now have for evidence-based treatments, which one of these treatments is precisely most likely to be effective for a given individual. And so this is really the holy grail, I suppose, this precision medicine approach. And as I've mentioned there, we have a large number of evidence-based psychological treatments now that have been shown to be effective. And that means that they work on average in terms of our clinical trials. Within that, though, the average effect sizes are modest. Like I said, when you average across individuals that do very well, stay about the same, and do poorly, you condense all of that and you end up with effect sizes that are modest. But for a given individual, the effect size for these treatments is not necessarily modest. And so we really need to understand this heterogeneity of treatment responses and what's driving that, what is underlying that, because it's likely influenced by the particular individual and what they bring into treatment, including both risk and resilience factors. And along with that, as Beryl really highlighted very well, it's not just the individual per se, but also their context, their socioeconomic background, their poverty levels. And so there's a great deal of contextual factors that surround a given individual, including both risk and resilience factors in terms of personality, psychological variables, behavioral variables, biological variables, but also those environmental factors. And so in terms of understanding this treatment variability in response, one way that my collaborators and I have gone about doing that is to start to look at treatment moderators. And moderators of treatment are basically those baseline patient characteristics that may or may not be theoretically derived that interact with treatment to affect outcomes. So that is the effect of the treatment for an individual depends on the value of the moderator, which precedes treatment and is really not associated with treatment per se. In terms of how do we go about identifying these moderators to test, there's really no consensus in the field about the moderators that underlie treatment response. Subgroups have been tested based on demographic factors, psychological factors, stress responses, psychosocial features, and the responses that have been identified based on patterns of adaptation as potential causes for the onset, amplification, and maintenance of symptoms. That most of this research to date has been driven by a lack of theory. So it's been mostly post hoc in terms of how the moderators tested have been selected. And certainly we do need these converging lines of evidence. These post hoc analyses really do have their place. And advancement of mechanism research also needs to be driven by theory as well. Until recently, though, there has not been moderation theories out there in terms of psychological interventions specifically for chronic pain. And so our group proposed the limit, activate, and enhance model, which proposes matching clients to treatments a priori to optimize outcome. And it's based on both matching to treatments on the basis of risk factors and also strengths or resilience factors. And this model, our limit, activate, enhance model, it's likely going to need revisions. It's likely going to need to be changed, updated, refined. It's really just a starting point to start selecting moderators on the basis of theory so that we can then move forward and tailor treatments to individuals so that they're most likely to be of benefit. And so if you're interested in learning about the details of this model, Professor Dawn Eadie and Professor Mark Jensen, we wrote this model up in 2015, and it was based on a review of the literature around the post hoc results that have been identified in terms of what factors seem to be important, and then also based on various theoretical perspectives that underlie psychological interventions. So this is a rather complex version of the model. Don't worry, I'll hone in on specific pieces here so you don't have to take in this whole slide. But the full model, as you can see, does include the need to consider contextual factors, the need to consider potential preparatory interventions. So preparatory intervention, for example, we've found in our clinical trials that one of the common predictors of dropout is actually baseline depression levels. So potentially a preparatory intervention might be a course of antidepressants before they engage in a psychological intervention, or maybe it's motivational interviewing to improve motivation. But what I'm going to focus on today is these patient profiles in terms of selecting moderators on the basis of theory. So if we hone in on a limit profile here and take a closer look at that, basically, if we look at this simpler version, this particular piece shows that if somebody has an excess of pain catastrophizing, for example, so an unhelpful coping response, then a well-matched intervention would be one that targets actually limiting that unhelpful response. And then we would see a reduction in that factor that would then lead to improved outcomes. But if somebody doesn't have an excess of pain catastrophizing, for example, then giving them a treatment to target that, which as would be the case in cognitive behavioral therapy, that's not really going to lead to a great deal of change because that's not a problem for that particular individual. Perhaps though, they're so-called couch potato, they don't engage in much activity. And so in that instance, they might have an activate profile, that they have a deficit of paced engagement in activity. And so they might need to increase that. And so then a well-matched intervention would be one that targets stimulating that helpful coping behavior, so potentially behavioral activation. And then you would get that change in activity level, which then would lead to improved function and improved outcomes. The model also includes targeting interventions on the basis of strengths and resilience factors. So the idea that we can actually use those strengths that people come into treatment with to build on that to, again, improve outcomes. And so a well-matched intervention for somebody that comes in with this resilience or this strength, would there be one that builds on that, and so that people learn to apply that strength to improve their pain coping and management. And then that change and that increase and that enhancement would lead to improved outcomes. So I'm going to share with you just some preliminary data that tested this theory. We have some larger trials that we are wrapping up here currently with my colleagues at the University of Washington. And so we'll be testing this model further. But this was the first preliminary test of the framework. And in this sense, we tested moderators that were selected on the basis of this limit, activate, and enhance model. And so the limit component of the model theorizes that treatments with cognitive techniques that are aimed towards really reducing maladaptive cognitions should be most effective for people with high baseline levels of cognitions. And so in this particular trial, we included a cognitive therapy arm to the RCT, and also a mindfulness-based cognitive therapy condition. And so given both the cognitive therapy and the mindfulness-based cognitive therapy included those cognitive techniques, we considered that those people with high levels of baseline catastrophizing would respond better to those interventions with those cognitive techniques included than if they were assigned to just a pure mindfulness meditation condition that did not have cognitive techniques targeted towards limiting pain catastrophizing. The model, the theory also, the activate component of the theory shows that treatments that are designed to activate adaptive responses. So in this case, we tested theta. They're best suited for those who have low baseline levels of that adaptive response being targeted. So in terms of the EEG measures, these slow wave oscillations, so these theta oscillations, they tend to reflect a focused, calm brain state that has been shown to also be cultivated with mindfulness meditation. And one prior study found that individuals with low baseline levels of theta, possibly in need of activation and boosting, that they responded best to mindfulness intervention. And so based on that, we hypothesized that people with low baseline levels of theta, this slow wave oscillation, that that would be an activate moderator in response to the mindfulness meditation condition and the mindfulness-based cognitive therapy condition that would not really influence outcome in cognitive therapy. Finally, our theory, the enhance component of the model theorizes that treatments designed to build or capitalize on strengths, that they're best suited to those who have high baseline levels of these strengths coming into treatment. And so given that meditation is designed to build on that inherent capacity to pay attention and to observe experience in a non-reactive manner, we hypothesized that individuals that came in with this trait, high levels of mindfulness, that they would respond best, and that would be an enhanced moderator in the mindfulness conditions in this trial, so within the mindfulness meditation and mindfulness-based cognitive therapy conditions. The outcomes, I should say, before I go forward, we looked at pain interference, pain intensity, physical function, and depression. And so if we look at the results of the limit moderator here, pain catastrophizing, we did find a significant interaction effect for the mindfulness meditation versus the MBCT condition. And what we found was that high baseline catastrophizing score actually predicted less improvement in pain intensity in MBCT. So this actually suggests that high pain catastrophizing might actually be an interference or vulnerability factor in mindfulness-based cognitive therapy, and that was a medium effect size found for that. Whereas to a lesser degree in the mindfulness meditation condition, although the effect size was smaller, as you see there, the results showed that higher pain catastrophizing score at baseline was associated with greater improvement. In cognitive therapy, you're seeing a bit of a flat line there. So this was not as we expected in terms of the pattern of results here based on our theory.
Dr. Day?
Yes.
I apologize. I'm guessing is the little bird that's so happy because the sun's coming up at your home?
Yes, unfortunately, I have no power over the birds.
Okay, I didn't know if there is, it occasionally is out vocalizing you, but if there's no way to do anything, then it's enjoyable, but it also
yeah, I have in my backyard I have a number of gum trees, and the parrots right now, they're gorgeous, they're lorikeets, they're all these beautiful red and green and blue colors, but boy are they noisy in the morning, and this is really their time that they come alive. But they're quieting down now, so hopefully you can hear me okay now.
Oh my gosh, too bad we can't see them too.
I know, yeah, they are beautiful, I must say, yeah. But sorry about that, I apologize about the birds. So in terms of our activate moderator here with theta, again, what we found was a significant interaction effect for cognitive therapy versus mindfulness-based cognitive therapy. And what we actually found was that those individuals with more theta at baseline, this was associated with greater improvement in depression in MBCT, whereas in the cognitive therapy condition, as you see here, high levels of theta at baseline actually interfered with response. And so again, this is not exactly in line with our theory. The interaction effect suggests that individuals with this relaxed yet focused brain state coming in, that they were able to build on this strength within the MBCT condition to improve outcomes. And this is, in hindsight, consistent with some research that suggested that individuals with high levels of theta, that they might actually be more readily able to enter into a meditative state. So rather than it being an activate moderator, it was possibly an enhanced moderator for MBCT, according to these results, which of course need to be replicated. Lastly, in terms of our enhanced moderator, we did find a significant interaction effect in the mindfulness meditation versus MBCT condition. And consistent with what we expected in terms of MBCT, we did find that higher levels of this baseline strength in mindfulness was associated with greater improvement in physical function, which is again consistent with that enhanced conceptualization. However, this was not the case in mindfulness as we had anticipated, where actually high levels of mindfulness at baseline actually interfered with response. So certainly we need to replicate these results to tease apart what's happening there and what's the difference between mindfulness meditation alone compared to the integrated approach with mindfulness-based cognitive therapy. So to summarize, what we found then was that those individuals with higher baseline pain catastrophizing, they might benefit more from mindfulness meditation than just a cognitive therapy or mindfulness-based cognitive therapy program. People with low levels of pain catastrophizing or high levels of mindful non-reactivity, for these people, MBCT might be best, that it can harness those baseline strengths to improve outcomes. But one caveat is that the pain catastrophizing score in this particular sample was low and was significantly lower in the cognitive therapy condition. So this really hindered our capacity to test that limit hypothesis of the model, particularly within relation to cognitive therapy, which may have been why we saw that relatively flat line on that graph for cognitive therapy testing the limit moderator. What this also suggests is that different brains, so to speak, might be more or less suited to different treatments. So those individuals with that slower brain waves, that more focused, calm brain state coming into treatment might do best with MBCT, whereas those with lower levels of theta might respond best to cognitive therapy. And really what this suggests, one of the take-home messages is that we need this well-rounded assessment of both risk factors and strengths that's indicated. And as you can hear from the parrots outside my window, they definitely agree with that. But really more research is needed, particularly in terms of testing moderated mediation, because it's likely that different individuals respond to different treatments because the mechanisms of change are either activated or they're not activated during treatment. So we definitely need that more nuanced understanding of how and for whom a treatment's effective and how does that come about. So we do need to move beyond this question of does it work to really look at for whom, and certainly in the last decade there's a great deal more research looking at mechanisms, and we also need more research on contextual factors like Birul was mentioning, and these theoretically derived moderators. And really with this cumulative effort in understanding these moderators, we will move towards precision medicine and patient treatment matching algorithms, which of course will lead to more efficient and effective treatment for a given individual. I would also say that this is definitely a team effort, the research and the theory and the ideas that I've presented here. So I'd like to thank my team and my collaborators, Mark Jensen, Dawn Eady, Beverly Thorne, John Burns, Chuck Ward, Jason Mattingly, and Natasha Matthews. And I'm fortunate to work with just the most wonderful people, and certainly I'd like to thank them. And also like to thank you and hand it back over to Dr. Sybil.
Thank you, Dr. Day. That was fantastic and highly relevant. And I think that it's going to come up again in our discussion. So now it is time for Dr. Bartley.
Okay, can we all see that? Okay, excellent. Thank you. I'm absolutely delighted to be here today with my colleagues to speak to you about resilience in chronic pain. So my goals for this talk are to provide some context regarding the literature on pain and resilience, especially as it relates to back pain, but then really talk about resilience from a treatment perspective. What exactly does a resilience intervention look like? And what strategies should we be considering in our interventions to help promote resilience? I do want to extend my gratitude and appreciation to ISP for hosting this webinar series on low back pain, which we all know is a really important topic when we start considering the burden that's associated with it. I'm sure that this figure is probably quite familiar to you, and I don't need to go over this in detail, but we know that low back pain reigns as the leading cause of disability worldwide. And I work a lot with an older adult population, and we also find that low back pain is one of the more kind of therapeutically challenging pain conditions that this population experiences. And the burden is even higher when you think about other medical comorbidities that are frequently present among older adults. Likewise, when we think about the pocket of people who experience high impact chronic pain, we do see a dose response effect in that older adults tend to report a greater frequency of pain that limits their life and work activities. So it becomes especially important to start thinking about how we can reduce this burden, and not just in older adults, but really in people with chronic pain more generally. So to do this, we need to continue thinking about the factors that are associated with pain and disability. And we know that pain is not just affected by biological or physiological factors. There's also a significant interface with psychosocial and behavioral factors that can both amplify and lessen the experience and burden of pain. So in addition to some of the more common biological drivers, there's also been an extensive amount of research on the psychological and the social factors that promote risk for pain, such as pain catastrophizing, having a low social support system, and even experiencing negative moods such as depression and anxiety. And so as you've been hearing about from my colleagues, there's also resources that promote resilience in terms of mitigating risk for chronic pain, but also helping people manage their pain better and improving their overall quality of life. So these can include resources such as positive affect and optimism, which have been studied quite regularly in the literature and demonstrate health promoting effects that extend much beyond chronic pain. There's even some nice literature showing that there's effects of these variables on reducing risk for mortality. And so moving forward as a field, we have to consider how these resources can help people with chronic pain and how they could potentially reduce the risk for chronic pain development. So we've actually reported on these factors in a series of studies in adults with osteoarthritis as well as low back pain, and finding some really nice support for their association with clinical pain, severity, and disability. So this is some of our data from a recent trial that we conducted with 60 older adults with chronic low back pain. And in this particular study, we had participants complete a series of measures that examine more dispositional or trait-based measures of resilience, but also measures that examine sources of resilience, such as optimism or positive affect, to name a couple. So what you're seeing here is data from the Brief Resilience Scale, which is a general measure of stress resilience. So people who are generally high on this measure, they tend to be the people who are able to adapt and recover from stress more readily. And so we were interested in whether pain and disability varied across levels of these levels of resilience. And so what we found is this nice dose response relationship, in that people who have higher levels of resilience, again, these are the people who are better able to adapt to stress. They tend to report lower levels of pain intensity and interference, as well as disability associated with chronic back pain. But they also report engaging in less pain-specific behaviors, such as grimacing or experiencing less emotional distress. And across a number of studies, our group has really taken this broad strokes approach to examining a wide array of resilience resources. And what we generally find is that these factors dampen the effects of negative psychological processes, such as fear avoidance, and how those resources affect pain. And we've also found some nice relationships and how these resources interact with sociodemographic characteristics to impact pain and function. So we've looked at this across race and ethnicity, and finding that the ability for these resilience resources to impact pain and disability is actually differentially expressed across race and ethnicity. And so what this tells us is that these factors are just as important as the vulnerability factors to take into account when we're looking at how people cope with and manage their pain. Another area that our group has been particularly interested in is this notion of what resilience actually is and how we should go about measuring it. So you've heard definitions from my colleagues, and in general, if you look at the literature, resilience is typically defined as this ability to adapt to stressors or adversity. But if you dig into the literature, you'll also see quite a few different definitions. There's a lot of variability in how resilience is defined and how it's measured, and even how it's interpreted. So our group has been working on this concept of multi-system resilience. And what we're doing in this is we're really starting to try to think about, again, what resilience is and how best to capture it. And considering resilience from kind of this interactive mixture of not only biological and psychological factors, but also personal factors and environmental factors, and what exactly that means in terms of how people adapt to chronic pain. So one disadvantage to our current models is that when we think about resilience, there's really this heavy emphasis on the psychological factors. And you'll find in the literature that most of the factors tend to be examined in isolation. But it could very well be that in order to be resilient in the face of pain, a person really needs to have a number of resources to help them be able to do that. And so this has led to some of our research in which we've explored resilience from a more biopsychosocial framework. So this was a study that we conducted in low back pain, where we really wanted to identify whether there were various components of resilience and how they interacted with one another to impact pain-related outcomes in this older adult population. And we did this by identifying factors in various domains and then employing cluster analysis to identify subgroups of resilience. And so here are the domains that we identified in this particular study. And so we focused not only on, psychological and social factors of resilience, but also honing in on measures of health resilience, which tend to have strong relationships with pain. And I'll go over this briefly, but what we generally found is the presence of 4 subgroups that varied across these levels of resiliency factors. So you have 2 subgroups that were either very high on resilience or very low on resilience in general, but then also 2 subgroups that differed across levels of psychosocial and health-related factors. So when we look at the results, the bottom line is that the more protective resources, the better. Individuals who have a higher degree of protective resources, so for those are people who have a greater resilient phenotype, these are the individuals who have better psychological and physical functioning. They report less sleep disturbance and fatigue, and they also report greater cognitive function. So we're seeing kind of some nice distribution across these various resilience profiles. And if we take these profiles and we look at them across levels of pain impact, we're seeing very similar results. So pain impact in this study was based upon the Research Task Force impact stratification criteria for low back pain. And so we stratified them against kind of this mild, moderate, and severe levels of pain impact, finding that if you have a higher levels of resilience across these particular measures, this does confer some protection against pain impact. And in fact, people who are generally low across the board, they have the greatest degree of pain impact. And so, when we think about these results, this may be the group that we really need to start paying attention to, and to think about how can we go about bolstering these protective resources and thinking about how can we bolster their personal levels of resilience, because this may be an important target to reduce the overall level of high impact pain. And so this brings me to the next topic, which is treatment approaches. can we use what we already know about these protective resources and develop strategies that are based upon a foundation of resilience? And if so, what exactly does that look like? So I'll be focusing in on a few different studies, and at the end, I'll be talking about some of the research that we're currently doing with chronic low back pain. When we consider our conventional psychological interventions for pain, they tend to focus on the reduction of negative symptoms. And this is generally in contrast to treatment approaches that focus more on harnessing personal strengths. Now, I do want to point out that our current psychological approaches, such as cognitive behavioral therapy, they do enhance resilience. But the distinction I want to make here is that, our traditional approaches are less specific to promoting resilience through targeted resources such as optimism and positive affect, for example. And if we consider these interventions that take on more of a resilience-based approach to treatment, they don't ignore risk. But the conceptual framework puts more of an emphasis on harnessing those protective assets and putting more of an emphasis on positive goals. So the interventions I want to highlight are those that really do focus on boosting personal resources and individual strengths rather than just simply alleviating symptoms and deficits. Here are just some examples of strategies and interventions that have been used implementing more of a strength-based approach to treatment. Many of these strategies, such as engaging in acts of kindness or expressing gratitude toward yourself or toward other people, or even inducing hopeful thinking, a lot of these have really been borrowed from the positive psychology literature with a primary focus on enhancing positive emotions. There's been a small number of studies in the pain literature that have focused on a single strategy within the treatment, but there's also been a handful of studies that have integrated a variety of activities within the treatment. So this is a study that I want to highlight. This was a positive activity intervention by Mueller, which was an 8-week study, and participants were assigned to either a positive psychology intervention or a control condition. And so you see a variety of different activities that they integrated within this particular study. So for the positive psychology intervention, these investigators had participants complete 4 positive psychology exercises, such as expressing gratitude or acts of kindness towards other people, or even selecting meaningful goals to work on. Or participants were randomized to another group that was just simply told to be more attentive to their surroundings and to write about 3 specific events or activities within the past 7 days. And what they particularly found is that in the positive psychology intervention, this intervention had more robust effects on pain severity relative to the control group, who just simply wrote about their life details. And then individuals who were in this intervention group had improvements not only in positive and negative affect, but they also reported significant improvements in life satisfaction and then a host of other clinical pain outcomes. And these improvements were even maintained at the 2.5-month follow-up period. Now, there's another follow-up study by the same authors that they found very similar effects, that when you compare a positive activity intervention to a control group, and in this case, the control group was told to be more mindful and to record current life events, they found that resulted in significant improvements in pain intensity, as well as positive and negative emotions. And again, effects were maintained over a period of 3 months. So, some nice support for these interventions and some sustainability over the short term as well. Another study that I want to highlight is a study by Madeline Peters, and this was an internet-based positive psychology program that compared that intervention to standard cognitive behavioral therapy, which we know is kind of a gold standard in psychological pain treatment. And their particular program really focused on exercises that were aimed at building self-compassion and positive affect, as well as inducing more optimistic thinking. So you see a number of exercises that were employed in the study, and some of these included having participants keep a self-compassion diary, focusing on the good things in their life, and then being aware of small daily pleasures. And what they found for this particular study is that, so these were the main outcomes of their study, and although they didn't see any significant effects for physical impairment, they did find similar effects for both the positive psychology intervention and also cognitive behavioral therapy, in that there were significant effects in reductions in depression, as well as increases in happiness when compared to waitlist control. And these effects were maintained for 6 months after the intervention. So there's also been some studies that have just focused on kind of single activities, such as this one, which really looked at loving kindness meditation. And this was a chronic low back population. So loving kindness meditation is an approach to developing love and releasing negative emotions, and it's been used widely for centuries in the Buddhist tradition. This meditation strategy involves using silent mental phrases to direct feelings of love and kindness. And you could do that towards a loved one or even towards yourself. You could do that towards all living things as well. So there's a variety of different ways in which loving kindness meditation can be employed. But in this particular study, they had 43 adults with chronic low back pain, and the intervention included 8 weekly 90-minute group sessions. And in general, they found that the more time patients were engaged in loving kindness meditation, the greater their decrease in pain was for that particular day. And also, they found that the more time patients put into loving kindness practice, the lower their anger was the following day. So this really does give some credence, not only towards these types of interventions, but also for support for the importance of dosing and how significant that can be in terms of producing some effects in these particular outcomes. So based upon these studies, there does seem to be some significant effects associated with these types of interventions. And this was actually found in a recent meta-analysis, which looked at 16 different randomized controlled trials. And the bottom line is that, this meta-analysis found that we do see these significant effects on pain and emotional function. And some of these can be quite large, and they're maintained over time, although we still don't know about the long-term sustainability of these effects. But with that being said, I do think it's important that, when you look across individual studies, more of these positive psychology interventions, some of the effects tend to be relatively modest, just as if you would look at some of our current treatments for chronic pain. Some of the effects of these interventions vary depending on the outcome of interest and what measures you're using, and also the population that you're working with. So it's really important to kind of think about some of these factors in terms of how you're building the intervention and what the interpretation of these effects are. So this finally brings me to the study that we're currently conducting in older adults with low back pain. And it leverages actually a lot of these various positive psychology approaches. So this is a pilot and feasibility study where we're primarily interested in whether the intervention is feasible to do and whether participants actually find it acceptable. But we're also looking at whether we can move the needle on various pain outcomes. This is a group-based intervention, and it spans 7 weekly sessions. And to let everybody know, we started off with this being an in-person group intervention, and then COVID hit. And so then we had to transition everything to kind of a telehealth program, which is actually going quite well. And then now we're actually transitioning back to in-person because we're finding that a lot of people are really wanting that in-person component. So it might provide some nice ability to kind of look at these group differences in our outcomes. But in general, the content that we've chosen for this particular intervention is based upon empirically supported strategies in the positive psychology literature, but it's also built upon some of our preliminary work. we conducted an earlier cross-sectional study with chronic low back pain, and we generally found that there were certain sources of resilience, such as positive affect and self-efficacy, that had really robust effects on pain and disability. So we've really tried to kind of build our intervention based upon those findings. And so in this intervention, we focus on a number of different concepts, such as building positive emotions through pleasant activities and practicing gratitude. We have people engage in goal-directed activities to increase hopeful thinking. So we have them establish a goal that they want to work on, and they work on that for the duration of the intervention. And then also have participants think about what do they find of value and meaningful in their life. And then self-efficacy is a big piece to this intervention. So we've been working a lot on ways to increase confidence and self-efficacy in everyone's own self-management. So this is an ongoing study. We are aiming to recruit 50 participants, and we have about 35 right now that have completed all the sessions. So I'll briefly kind of review what we've been finding so far. So again, the primary goal of this study is to assess feasibility and acceptability. And here's an example of some of the questions that we have that tap into these things. What we're finding is that participants tend to be relatively engaged in the intervention. They've been finding the activities to be beneficial and useful, and overall, they're reporting high satisfaction with the treatment components. And we have been finding that once participants enroll in our study, they do tend to stay involved. So luckily, we're not seeing a lot of attrition at this point. We're also seeing some significant effects in our primary outcomes. In particular, pain interference and intensity are showing significant reductions from pre to post intervention. And then, although depression is not significantly high in our particular sample, we do see reduced scores on depressive symptoms from pre to post. And then also, we're seeing some changes in quality of life in respect to psychological function. So that's increasing over the intervention period. Some preliminary effects that are looking nice so far. So, hopefully we'll have some final results in the next few months that we are going to be able to share with everyone. So kind of in sum, there does seem to be some nice evidence supporting the beneficial effects of a variety of protective resources in chronic pain, and also, supporting the utility of utilizing these strength-based approaches in chronic low back pain. Moving forward, we have to start thinking about how can we use these strategies to promote better pain outcomes, and specifically gain a better understanding of which components should we be integrating in our current therapies. Because right now there's really no gold standard or best practices in place for how to effectively build resilience, especially in chronic pain. This provides a really nice research opportunity and to think about ways in which we can help people capitalize on their strengths to build a more resilient profile, and not only mitigate, the effects of chronic pain, but also to think about how we can use these strategies in prevention research. So this leads me to my final slide before we open it up for questions. I'd just like to acknowledge my funding resources and just extend my appreciation to the people that I have the opportunity to work with at the University of Florida.
Thank you, Dr. Bartley. So we are at the 5:28. We have 2 questions in the question and answer. And I am wondering from IASP, do we have the option of continuing with people disconnecting, or do we need to end this at a solid 5:30?
You can go ahead. Please feel free to continue the discussion, and everybody that needs to sign off can catch the recording after.
Oh, fantastic. Okay, onward we go. And thank you, everyone. It was exciting to see everyone saying hello from all over the world. Amazing. So let's start with the questions that are in the question and answer chat, and then we have a few if our panelists are still willing to hang out for a few others that are part of the PowerPoint. So the first one is, what is the influence of factors of work like blue flags and black flags in resilience?
That might be directed toward me.
Thinking so.
But I might need some help with that. Perhaps this question has an international slant to it that I'm not as familiar with as a United States citizen. Blue flags and black flags, what does that mean?
Is this like work-related factors that can impact resilience, such as looking at the culture of the workplace that you work in, such as the sick policy, whether people are happy or not in their workspace, high job demand, stress associated with that? I think that may be what this is tapping into.
Okay. All right. Well, that would make sense. And to the extent that that's indeed what it is, that's something that we built into the study that I mentioned earlier. We have some of those data. I haven't quite looked at them yet, but things related to just occupation type. And then we have some information related to occupational prestige, satisfaction therein, and then things like sort of job flexibility. So, to what extent where, hey, you got a nice opportunity for a vacation. Can you go take it? Or is it a problem because you only have 3 days worth of vacation time at work or whatever? Those sorts of things related to occupation, I think, are going to be important for things like chronic low back pain and the experience therein. In interesting ways, right? Because whether or not you work at a construction site all day, that might confer risk, right, to low back pain, but also too, maybe sitting at a desk chair in a sedentary position all day may confer risk as well, right? But then there may be some interesting sort of moderators in there, to get at what Mel was saying, where if you are doing the construction job, you may not have the opportunity to take a break and go for a little walk or take a load off, where maybe with a job where you have a little bit more control over how you spend your time, you might be able to get up and walk away from your desk chair. So there's a lot of subtleties and nuances in there, but I think that's going to play an important impact on people's experiences of pain and their ability to be resilient or not therein. So it's a little bit speculative. We have some data related to that, but hopefully that answers some of that. I'll stop there.
Great, thank you, Dr. Gooden. So the next question is, do you think we need to create more complex classification systems to deal with the heterogeneity or educate healthcare professionals in more integrative and interdisciplinary approaches?
All right.
Dr. Day or Dr. Bartley?
Yeah.
Who would like that one?
Sure, I can have a go at that one. Can you hear me okay?
Mm-hmm.
Yes.
So I think it's an excellent question, and I think it ties into both Emily and my presentation some to a certain degree. That I think Emily's tie-in of the multi-systems perspective in terms of coming up with subgroups of individuals on the basis of biological, psychological, social, contextual factors, and how that might build various resilience profiles. I think that's an exciting next needed future direction of research, that we can actually look at these more complex multi-system approaches in terms of response to different interventions, and certainly how that informs interdisciplinary care was the other part of the question, and also I think expanding awareness among other professionals of the capacity of psychological interventions to improve outcomes. That's certainly here in Australia, there goes the parrots again. Yeah, certainly that's a needed direction here in Australia as well, but also access. Because it's not necessarily that physicians or other professionals don't know about what we do, but certainly waitlist access to interdisciplinary care and psychological interventions is a massive issue, and so we need to come at it from a number of different directions.
Yeah, we've been working on this for a little bit, because my idea is that resilience is just so much more like than the psychological piece to it. The problem is that you have to think about what are those resilience pieces that you include, because you can imagine that the list could go on, and then you have this huge algorithm that you have to work with, and then how do you deal with that statistically? But there is some nice evidence for these various subgroups, and not just looking at resilience, but looking at even vulnerability factors and how they're associated with various outcomes, how it's also been implicated in treatment-related outcomes as well. And so we have to think about, what are those important variables that we need to be considering, not just psychologically, but biologically, or, socially, environmentally. Dr. Gooden touched on that. And an area of interest is social determinants of health, which is really big right now. So, we have to think about how we can do that and how we could integrate that easily within a clinical setting so that it's not burdensome, almost like you're creating some sort of a clinical index of resilience.
Thank you. We have a question here for Dr. Day. So thank you, Melissa, for the fantastic presentation. Wonderful work. Did you measure compliance to treatment? If so, did any sensitivity analysis alter the interaction effects?
Thank you. It's an excellent question. We did measure compliance in terms of their session attendance. The programs were 8 weeks, they're in person, delivered by me, and then also their homework completion. We didn't have statistical power to look at how that might affect the interactions that I showed, but in terms of the dose response, in terms of how that affected outcomes in this particular study, we didn't find a relationship between amount of practice or compliance, if you'd like to call it that, and outcome. But that's also perhaps a difference between the data that I presented versus some of the data that Emily presented, was that we didn't have a no treatment control or a control condition. So all 3 were active treatment. So it makes sense that there were relatively equal doses there and relatively equal compliance. And so I think, yeah, if we had a control, we might have found more of an influence there, but a limitation of the study.
Thank you. And there's another question here of how would you incorporate positive psychology and boost resilience without going into toxic positivity or triggering guilt and shame over the inability to be positive?
An excellent question. I don't know if anyone else wants to take that one on, but I will say we're not trying to be positive Polly here, with our positive psych interventions. It's certainly got a dose of realism, but Beryl, did you want to have a go at that one? You'd unmuted, so.
I know. And I always wear hats. Well, let me put my clinical hat on. So, when I'm in the clinic, now as a midlife individual, when I'm in the clinic seeing a patient, perhaps my approach was a lot different than when I was like fresh out of grad school. Let me explain that. I don't know. I kind of just grew up in a blue collar family where you didn't get a participation trophy. You only got a trophy for first place. So, better luck next time, try harder sort of thing was always kind of how it went. And that was initially sort of my approach to treatment, was like, well, yeah, I know you showed up, but you do what you're supposed to do, right? Like, and that's how you get the treatment benefits and stuff therein. And over time, just affirming people's efforts, I started to get very Carl Rogerian. If anybody's familiar with psychology and clinical psychology there, where it was just unconditional positive regard. Even though a person was down on themselves, oftentimes the depression was almost the toxic piece, and just trying to reframe it to be like, yeah, but you thought really hard about this. And even though you weren't able to translate that thought into action this go around, you're moving your head into the right space. And that's an important step, right? Because, ultimately it's sort of unlearning some bad habits, trying to learn new ones that promote resilience. So oftentimes even trying to be unconditionally positive and regarding individuals wasn't really toxic positivity. It was just trying to untangle folks from their sort of toxic depression, right? And kind of pointing them in the right direction with that idea of, first you crawl, then you walk, then you run, right? In terms of promoting resilience. Again, that was a lot of my just anecdotal experience. Maybe that resonates with what other people experience, but But toxic positivity oftentimes wasn't something that I felt like I was coming across very often. It was usually the opposite.
This has actually been a conversation I've had with some people, and I'm working with a student from country in Europe, and she talks about how her country is going through a lot of economic instability right now, but their population is deemed as resilient because they just keep pushing forward. And the people that live there are like, no, we're not resilient because we don't want to deal with this adversity anymore. We shouldn't have to deal with it. And so it gets into the kind of this conversation of, is there such a thing as this toxic resilience? Can you just be too resilient? And I think that there is some evidence that, being too high, like especially on optimism, can actually confer negative effects. There's even some interesting research looking at people who are really highly resilient and how that actually has adverse outcomes on their leadership abilities. So it's really kind of an interesting literature base. We tend to think of positive psychology and resilience as being this good thing, but maybe there's a dark side to resilience as well, and thinking about kind of those individual differences in that, and how do we, everything in moderation, I guess.
Yes,
that's interesting. Let me say that. Yeah. So if you look at it, we still got 74 participants on this talk, right? Who are sort of brave souls who we've gone over time, resilient individuals who are hanging in there to learn a little bit more, right? And you could probably go ahead and step out on a limb to say that these resilient individuals are the go-getters in their departments, right? And they work real hard. And if anybody who's been in academia, academia has maybe jaded me a little bit, but if you've been in academia for a little while, when you do a really good job, what do you get rewarded with? More work, right? So, in that regard, sometimes maybe that's a bit of the dark side of resilience there.
So, all right, we're going to head to a couple additional questions, hopefully, for all these resilient people that are hanging in here, including the panelists. So we have two that for non-psychology healthcare professionals, physicians, other healthcare providers that do not have a psychology background. One question is, how do we encourage that they assess unhelpful coping strategies within patients with chronic low back pain? And the other question is going along the line of, how can a primary care doc manage these in, say, an 8-minute consultation? So how might resilience be addressed, with a healthcare provider that has 5 to 10 minutes? It's not the 1 hour, psychotherapy intervention.
Quick hot take, I believe, so we're all psychologists here, right? And I still tell people, like, what we do is not like rocket science, right? So they're like, man, just the clinical psychology thing, we can't do it as allied other professionals, physicians or whatever. It's not necessarily the case, I would argue, right? I mean, some of the intricate assessment things perhaps or whatever, right? But if I've got like 10 minutes with a patient, I'm going to say, like, what do you do with your day? How do you spend it? All right. What brings joy to your life? Like, how, what do you like to do? What are your values? Right. And see how they articulate that. And if it's extremely challenging for them to articulate, that might suggest to me that there's some issues with engaging in like fun activity, like resilience promoting types of things. And I might be a little bit concerned with that, right? I mean, to an extent that person's like, I got this chronic low back pain, but I realize that if I sort of like limit what I do at any given time and sort of pace myself, I can still do some stuff. And I'm like, oh, that's activity pacing. That's actually a very potent psychological intervention there, right? And they explain it to me. So I kind of go about it like that. I don't necessarily say, hey, I need you to complete this resilience measure and then I'll read it afterwards, because part of it is just being human, right? Tell me about yourself. What's going on? Now I feel listened to. This person cares. Step one, that's the cornerstone of anything that we're going to do, is that therapeutic alliance, right? That base, right? That promotes a durable, resilient patient-provider relationship in and of itself. And then, as I start to say, tell me about yourself. Oh, well, interesting. And then, and that doesn't take very long. And if you speak really fast like me, you get a lot in there.
Yeah, somebody put in the chat the value of motivational interviewing, that's absolutely true. Motivational interviewing could be so important in various populations. I think establishing therapeutic rapport is, very, very important as well, and can really kind of dictate, what exactly happens in that therapeutic setting. I mean, if we're thinking about, just small types of interventions, education is a big piece to that, but asking people, well, maybe over the next time that I see you, try to engage in a pleasant activity. Maybe go out and savor some pleasant experiences. So I think that you can take some of those existing activities from the positive psychology literature, and it doesn't have to be something that they, that you have like an 8-session intervention with them. You just simply tell them what they need to do. And a lot of these are self-management. They can do on their own and quite easily.
Mm-hmm.
Yeah, I was going to chime in actually. Thank you to the person that typed in about motivational interviewing, Carlin, because that actually research has shown that that's something that does not add to time during quick physician visits, that actually with those motivational interviewing skills, you can actually get to the point much quicker because people feel heard and that they're tapping into their own reasons for behavioral change. And as Kimberly pointed out in the introduction to this talk, that so much of our health is related to our behaviors, what we're doing. And so if you're looking for a brief little training, you can get training in motivational interviewing. It's a skill set that's so useful no matter what your profession, and it really allows you to help the person tap into their own inherent reasons for behavioral change, whether that would be engaging in more pleasant activities or mastery oriented activities, tapping into their personal reasons for change.
Thank you. And I just will offer a quick comment to this, that I am working with a number of colleagues, including Dr. Bartley and others here at University of Florida and Wake Forest, and we are working on actually developing a resilience index, and that will capture key areas that would help just as a quick clinical target and allow providers, perhaps not to the depth and extent that we would have with some of the psychological interventions identified. But what we've also seen is there's good evidence for some simple lifestyle areas and other cognitive strategies that can be targeted and be effective. And so that's one of the areas we're hoping to have some future findings on. There's one other question here in the question and answer section, and I have one last one for the panelists if they're willing to engage me in that. And then it looks like we'll probably be concluding, but we have a question showing or asking that research has shown that exercise is effective, but the effect size is small, and that people with musculoskeletal complaints may experience pain at rest. Are they not resilient enough? And I think these are some fantastic questions. I am now in the Department of Physical Medicine and Rehabilitation at the University of Florida and was actually attending a seminar on these areas. I think there are actually impressive findings about the benefits of exercise. Some of the limitations may have been specific to the approach, maybe not the best in sort of differentiating and phenotyping some in the sample. If the individual who posted that, if you have any interest in emailing me, I would be happy to send some additional references that you might find interesting. Based on the fantastic talk I actually had the opportunity to hear earlier today. We had a few additional questions, but I think what I'd like to do, if the panelists don't mind, is what we have here are a list of quotes and comments from some great thinkers and great researchers. And I think if we were to conclude this talk with one overarching response. The question is, as we move forward, do you think what we need to be doing is decreasing risk and increasing resilience, or focusing only on increasing resilience? Maybe just, we've actually heard some of the answers within the different talks, but maybe just a 5 or 10 second response from each of you. And I think this may be a great concluding comment.
I would say we need to work towards both. We know that, resilience is not the opposite of vulnerability. And even in our own work, we find that these resilience factors are actually interacting with the vulnerability factors to impact various pain outcomes. So I think if we need to build a more resilient profile, we need to not only harness the strengths, but also kind of reduce the risk factors as well.
Excellent. Dr. Gooden.
Yeah, I would concur with that. But let me just emphasize, like in terms of building resilience, I think there's a lot of room left in terms of intervention land to come up with ideas, novel, and how to do that, ranging from focusing on the individual, the person you have in front of you for, say, 15 minutes, 30 minutes, an hour in your clinic slot, right, to the community, right, level of building resilience, right, some of the neighborhood stuff that I was mentioning, all the way up to the various policies within the towns, cities, countries in which we live, right? And some of that may be above my pay grade. Policy isn't necessarily my wheelhouse, but my point being is that I think we also need to think on a very sort of systematic level how we can build resilient, right? Resilient people, resilient families, resilient communities, resilient countries, so forth and so on.
Thank you. And I recognize you guys were not able to see the statements earlier, so hopefully you can see those now. And Dr. Day, any concluding comments?
I think in terms of your question, whether it's more important to reduce risk or vulnerability or build strength, my sense is that it would be based on the individual, that there's a lot of individual differences in what is needed, and risks and strengths are interconnected, and in different contexts, what can be perceived as a strength might actually turn into a weakness and vice versa. So I think really it's not either or black and white, or perhaps not even the kitchen sink thrown at everybody, but just more of this individual perspective of what does that person need at this point in time, because it will change over time as well.
Excellent, thank you. And I just wanted to highlight in a, let's see, get past these other questions due to time, and I think we've worked through, but I was alerted today by a colleague, Dr. Mark Pitcher, about the work that is going on specific to resilience in the NIH. So if you guys, anyone who's still on call or with the recording, that you can search this on the website. There's some really exciting work moving forward in the area of resilience. And so then on that note, keeping in line with the focus of the topic, it's extending thanks and gratitude for those that have done the work on resilience efforts. It looks like going back to Socrates and perhaps even before, for IASP for hosting this event, to our fantastic panel of presenters, Dr. Good, let's see if we can get this out, Dr. Gooden, Day, and Bartley, and then to all of our attendees, as well as to the NIH and other funders of these efforts. And then for me personally, to the team members and collaborators working in the pain trail. So thank you very much. Great afternoon, morning for others. And we appreciate everyone's attendance and participation.
Thank you, everybody. Appreciate the opportunity.
Thank you.
It was a pleasure.
Take care.
All right. Bye now.
Thank you. Bye-bye.